This is a preview of the lecture video on the topic four-chamber view of fetal echocardiography. The snippets of the various topics covered under this lecture video will follow. Having gone through the preview, if you wish to listen to the main lecture video, go to sonoshare.in. Once you reach the website, this is the home page. You scroll down the home page and you will get the icons of various lectures available, and click on whichever lecture you want to subscribe. You would have seen the preview. You want to subscribe for the lecture. So click on the icon. And if you have any doubts, you can also see the ShonoShare guide, which is available in the home page in case of any difficulty. On the fetal thorax, then you will go to preview page of the lecture video you have selected. So you click on the red bar and it will go to the page of the particular lecture video, the amount and the duration you can watch. And you click on the buy and it will go to the payment page, make the payment, and you will receive a confirmation email. Once you get the confirmation email, you log and view the lecture video. Thank you.
Topic, four-chamber view. And the technique is axial sweep technique. You follow the checklist and look for the organs. So here, this is longitudinal breech and spine posterior. So this will be left and longitudinal cephali. And then we come to now the upper abdomen. So before the four-chamber view, there is a upper abdomen. In the upper abdomen, the checklist is you have to see the stomach azygas, which is seen in a left atrial isomerism for the four-chamber. Now the guidelines say four-chamber view. So you have to be careful about all the structures in the four-chamber view. So you cannot afford to miss anything from the four-chamber view. So the four-chamber view is very important, and most of the anomalies we pick up, say about 50% of the anomalies we pick up from the four-chamber view, and we will see one by one the recognition. So as seen here, this is normal four-chamber view. Here immediately you see that the left ventricle is small. So this makes us life easy. So during course of time, you will identify the abnormalities by pattern recognition. And then you arrive at an abnormality, which is the lead point. So you see one abnormality, which is the lead point sign. That is not the complete diagnosis. So, and you do also spectral Doppler if it is necessary, and then an M mode if it is necessary. Different checklists. First is the situs. Now situs can be solitus, which is normal, or it can be inversus or 0.1% of fetuses, and where there is inversus of the organs. So here longitudinal 1 per 10,000 infants, and with this situs ambiguous, there is significant increase in complex cardiac anomaly, and most common of which is heterotaxy or the isomerism. Now situs ambiguous, here you see so that is about situs abnormalities. Then we come to the axis of the heart. So axis is assessed subjectively, or if you can put angles, AVST and then common atrium and gastroscopy, other extracardiac anomalies of the heart. And in dextrocardia, the various changes in the position of the heart is one is dextrocardia. Now dextrocardia can be dextroversion or dextroposition left, whereas the stomach is on the right side. This again will be associated with an increase in cardiac anomaly, incidence of cardiac anomaly. So you see here the ORV and isomerism, and it is also seen in when there is increase in volume of both the lungs, which happens in chaos, congenital high airway obstructive syndrome, contract equally on both sides. So as a result, you don't see any movement of the interventricular septum, and these are the various conditions where there is abnormal contraction, relaxation of the ventricles, both the right ventricle and the left ventricle. Here, this is hypoplastic right ventricle, non-contractile. So here you see that the right ventricle is contraction of the chambers. Then we come to the chambers. So chambers are two atria and two ventricles. The atria are similar in size, and the left hand position, the left ventricle is posterior into the left, right ventricle is anterior into the right. They are similar in size. You have hypoplastic left ventricle. It should be severely small, and apex should be formed by the right ventricle, and it should be non-proportionately smaller left ventricle. So the ventricles, I said, are equal in size, and when you take RV to LV ratio, it should be normally about 1.19, but now normally the ventricles are equal in size. And here you see that the ventricle is the left ventricle is dilated normally. Now here you see the dilated non-contractile left ventricle and alacing across the leaflet of the tricuspid valve, and in color you see gross tricuspid regurgitation starting from the single ventricle, or it can be an extreme form of hypoplastic left heart syndrome or a pulmonary atresia with intact blood drains the coronary veins from the heart, and it is seen at the groove, AV groove coronary sinus. You see that coronary sinus draining into the right atrium, which is dilated, and flow is from left to right, and there is no additional vein in the 3VT. So in 3V veins join. So this is called triatrium sinister, well, more apical. So that is the right ventricle in the place of left ventricle. So that is abnormal position of the ventricle. So when you see like this, then you have to see definitely an anterolateral approach, because that is perpendicular to the beam, and it is broader towards the apex and thin towards the AV groove. So showing the muscular VSD. In grayscale it is seen, and that is the bidirectional flow in muscular. It is an offset. It is not at the same level. So that is the crus, and because of that, there is part of a septum which is between the right atrium and left ventricle. That is the atrioventricular septum. So the septum has got three parts. The intraventricular septum compared to normal in AVST, and the normal AVL is 0.5. If it is more than 0.6, then we must think of. Then we come to the atrial septum, where you see this is the atrial septum, and that is augmented appearance of the foramen flap, which is previously was called as aneurysm of the foramen flap. So this is normal only. Fistula, arteriovenous fistula here. So there is a direct communication from the pulmonary artery to vein, resulting in that. The differential diagnosis, as we discussed earlier, is a dilated coronary sinus, which will be crossing to join the right atrium. So the differentiating points will be, if it is coronary sinus, you will see a dilated coronary into the atrioventricular valves. So the atrioventricular valves, because they will be perpendicular to the beam in the apical approach. So they will be seen better in apical approach. You see the two separate closed, and diastole its valve is open, but the tricuspid valve is self-like both in systole and diastole. And color, you must go from lateral approach, and you see the two pulmonary veins in opposite color. And when you do spectral, you get the typical M pattern in the esophagus there. So the space is not much between the aorta and the left atrium. Whereas here you see the aorta, which is valves are very echogenic. So that is on the right side. So when you see this, then dilated azygos, then you must think of interrupted IVC with azygos continuation. So go to the upper abdomen, the echogenic center with an echopore ring around. When it is empty, or transiently, you may see a full esophagus fluid. Space behind the heart is TAPVC. See here, the left atrium is close to the aorta, which is normal, whereas here the left atrium is far away from the aorta, that is rhabdomyoma. So when you see rhabdomyoma, it may be forming part of tuberous sclerosis. So you must, now here it is only the left ventricle which is involved. It fails to contract and it is dilated, whereas the right ventricle shows nicely. And if you see, there is a focal bulge of the left ventricle. so indicating that it is an left ventricular aneurysm, and already the heart is failing, indicated by echo poor rim, which may be a pericardial fat. It has to be differentiated from pericardial effusion. What are the features? The thickness should be more than 2 millimeters. It should cross the avid mass, and there is some amount of pericardial fluid. And where is the location? It is between the groove between the right ventricle and pattern recognition. Then proceed on to the lead point, pick up one abnormality, then go extended examination or a sequential segmental analysis and arrive at a final diagnosis. Thank you very much for